Hi everyone, my name is Dr. Travis Gagen, and I'm delighted to be joining you for the Third World Aging and Rejuvenation Conference in Barcelona, Spain. Today I'm going to be presenting a recent publication titled Improving Local Service Delivery to Prevent Falls in Community-Dwelling Older Adults, Translating Research to Practice, published to the Gerontologist through the Oxford University Press. The manuscript addresses unintentional falls and presents a conceptual model to improve local service delivery of fall prevention programs targeted for community-dwelling older adults. The conceptual model can be used as a guide for policymakers and public health practitioners as a way to translate existing fall prevention evidence into practice. As the United States demographic increases in older adults 65 years of age and over, unintentional falls increase as well. Unintentional falls pose significant risks for older adults who experience a fall, such as musculoskeletal injuries resulting in nursing home admissions. Oftentimes, this can result in cases of pneumonia as well as fatality. There is both individual as well as societal economic burdens for those who experience a fall. For an individual, an increase in healthcare costs from $1,500 to $2,500, to societal burdens to the Centers for Medicare and Medicaid, exceeding $31 billion to treat fall-related injuries. One of the problems that my colleague Maria Balz-Kelly and I have identified is that the United States health and public health systems lack a comprehensive fall prevention surveillance system, as well as the implementation of local evidence-based fall prevention programs. This is a problem, given the fact that fall-related mortality has increased over the last decade and remains as a significant cause of fatality for the older adult population. You can see here that the Center for Disease Control now classifies unintentional injury for older adults 65 years of age and over as one of the 10 leading causes of death in the United States. As age increases, so too does the fatality rate of those who experience a fall. If you are an individual 85 years of age and over and experience a fall, you have an 85% chance of fatality resulting from that fall. Therefore, it is important to prevent falls. Unintentional falls indeed are preventable. Evidence suggests that exercise, nutrition, as well as home safety assessment and modification all significantly reduce the risk of falls for those who have not yet experienced a fall, as well as reduces the chance of someone who has already experienced a fall, thus allowing them to remain in their home and community independently and avoid institutionalization. Wide-scale adoption of these evidence-based fall prevention programs has not yet been integrated into the local health and public health infrastructure of the United States. Moreover, little is known about local interagency collaboration in regards to efforts to implement fall prevention services. Therefore, the purpose of this study was to present a model of how evidence-based fall prevention can be incorporated into the existing health and human services infrastructure at the local level with the intention of reducing the rate of falls. The conceptual model employs three theoretical frameworks. The first, a framework suggested by Donna Bedian in 1980, the Structure Process Outcomes Model, informs the overall structure of the conceptual framework. The next is the Precaution Adoption Process Model, which helps to evaluate local agency director behaviors in regards to service provision or understanding their behaviors of not offering certain service provisions, such as fall prevention programs. The last addresses examining interagency collaboration as well as evaluation in outcomes using the MAP-IT framework proposed by the CDC recently. Here, all three theoretical frameworks are incorporated to examine the implementation of evidence-based fall prevention programs through the delivery by the local public health systems. You can see here we examine the structure, the process, and the ultimate outcomes of implementing evidence-based fall prevention programs. Let's take a closer look at how this model addresses the problem. The local public health system is important in regards to local service provisions, as well as connecting community dwelling older adults to prevention programs. The precaution adoption process model here is informative of understanding local agency director behaviors in service provision. How engaged and knowledgeable are they of evidence-based fall prevention programs? And what is their decision-making process like in regards to service provision or not offering certain services? So the precaution adoption process model informs the stage in which program implementation is being considered at the local level. By identifying agencies' behavior, we can look at the reasons for or against service provisions, and we can emphasize stages 5 through 6 using the precaution adoption process model. This also allows gerontological and public health professionals to tailor dissemination efforts to agency directors who may be in stages 1 and 2. Going back to those are program directors who may be unaware of the issue of falls or unengaged in the issue at that time. Another implication of this model suggests that we can direct technical assistance or funding support for agency directors who find themselves in stage 5. Here is the decision to act on implementing evidence-based fall prevention programs. Therefore, the precaution adoption process model helps to tailor and direct scarce resources to those at various stages. Let's explore further the model components. The structure incorporates local service delivery that relate to services and programs for older community dwelling adults. The area agencies on aging have an inherent legal commitment to serving their local community in implementing local service programs for home and community-based older adults. The local health departments have the authority to pursue and implement fall prevention activities. However, in our findings, only approximately 20% of local health departments do adopt fall prevention programs, which was a very low number in regards to the actual delivery of evidence-based fall prevention. The healthcare system, particularly healthcare providers who interact from a clinical perspective with older adults. Under the Section 4103 of the Patient Protection and Affordable Care Act, it covers wellness visits, which can assess the individual function and safety using a health risk assessment to identify a potential at-risk faller. Also, according to the Tax Relief in Healthcare Act of 2006, the Physician Quality Reporting System incentivizes voluntary screenings of at-risk patients and recommends follow-up fall prevention services, if available. Last, first response agencies such as fire departments, police departments, and paramedics all have the first interaction for most home and community-based fallers providing a very unique opportunity to connect older adults with fall prevention services. However, this aspect of the structure is not only underutilized, but the most under-researched area of the model. Interagency collaboration remains important. Here, it is known that interagency collaboration improves the performance of service program delivery, and it also allows us to target scarce resources for at-risk fallers. I provide two examples of how interagency collaboration can be incorporated in order to prevent falls. The process in regards to the delivery of fall prevention services addresses directly the Healthy People Initiative Objective Older Adult 11, which is to reduce the rate of emergency department visits due to falls. Here you can see that fall prevention interventions are supported by evidence and should be widely adopted. Thus, using the MAPIT implementation framework is a helpful guide in order to look at the way that these programs can be monitored through tracking and evaluation, as well as a surveillance system. Surveillance is critical to the success of the public health approach. And surveillance specific to fall prevention could certainly enhance the way that service provision is delivered. Interventions are evidence-based across exercise, nutrition, and home modification. Here you can see that leading evidence-based criteria such as Tai Chi, as well as other resistance training programs, significantly reduce the rate of falls. Nutrition programs improve stability and function, as well as address psychosocial aspects related to falls. The existing framework of the Older Americans Act, such as the delivery of Meals on Wheels, can be incorporated into the local service delivery framework. Home modification programs exist and suggest significant improvements in reduction in falls. Fall prevention surveillance systems are a key aspect to the success of a fall prevention framework. Our surveillance system can be used to meet the three core essential functions of public health by generating data for measurement and evaluation, monitoring local health department performance, as well as increasing the bidirectional interagency information sharing across agencies. Pre-existing surveillance systems do exist and have supportive evidence to suggest positive health outcomes in regards to reducing falls. The surveillance system incorporates the healthcare system as the primary identification through annual wellness visits as well as quality reporting systems. Therefore, at-risk fallers can be identified and referred through documented procedures, ensuring HIPAA compliance, and then enrolling an at-risk faller in an evidence-based fall prevention program, thus connecting them back to their home and community and helping them to increase their function and their capacity to live well in their home and community. The ultimate outcomes of our model look to reduce falls, unintentional injuries, healthcare utilization, and costs, and ultimately increase the independence and well-being for older adults. Our model certainly can guide the implementation and evaluation process. It can help to set outcomes to monitor the performance of local public health and healthcare systems in terms of program planning, evaluation, as well as the precaution adoption process model for decision making. Finally, widespread implementation is necessary, and local agencies we know can play a crucial role in facilitating the adoption of these programs. Our ongoing research suggests that smart home technologies should be incorporated into such an evidence-based model. However, barriers to smart home technologies do exist, but as the aging demographic increases, there is a general acceptance of smart home technology utilization to be employed to reduce the risk of falls and remain independent in the home, a desire by the overwhelming majority of aging Americans. Last, reforms to a housing policy may be necessary to address the third evidence-based program, which is home modification to prevent falls. Thank you for your time and for your consideration of reviewing my manuscript on fall prevention.